Thank you very much for the opportunity to talk about a topic that is only really coming into the fore now. And I'm really going to focus on some of the clinical consequences that we expect to see as children are growing up with HIV and reaching adulthood. And as Anita has said, ART has extended lifespan, and particularly with adults, we are seeing really large numbers sort of growing into a cohort of older individuals. As you can see, 5.4 million in 2015 to 8.1 million 2020. And aging isn't just happening in adults. Aging starts, chronological and biological aging starts since birth. And so we are seeing increasing numbers of children with HIV now reaching adulthood. That said, we've also heard that challenges persist despite antiretroviral therapy. And what we've observed in adults, at least, and there's been a strong focus on this as adults grow older with HIV, is a focus on addressing the risk of multimorbidities, which we're seeing in increased frequency in adults with HIV compared to those who are not living with HIV, even after allowing for confounding for some of the factors that could drive these comorbidities. And what is increasingly being recognized is that children with HIV are also at risk of multisystem morbidities, which decrease health span. And this is a study that I think Lisa led some years ago. She's somewhere in the audience, which I quote very often because it gives a very nice overview of what is happening to lots of systems in the body. And what the CTAC cohort in Cape Town found is that there's a very high prevalence of both single, dual, and multi-system comorbidities in individuals growing up with perinatally acquired HIV compared to those who were not infected. And importantly, the most common ones are cardiac, lung, and neurocognitive disease. And I'm just going to touch on a couple of them. So really, cardiac disease is the one that most people are very familiar with. And we talk often in much of the literature in the global north focuses on sort of metabolic syndrome and sort of a cardiac profile that's similar to that seen in adults, which is driven, which is sort of arteriosclerotic in nature. What we're actually seeing in children is a post-symptomatic profile, so very little, but when you do majority of the studies that have used transthoracic echocardiography, find a really high prevalence and incidence across adolescents of left and right heart disease, and sort of both functional and structural abnormalities. And obviously, as you know, transthoracic echocardiography is a fairly coarse tool. So there are beginning to be studies in Africa, particularly using cardiac magnetic resonance imaging. And a couple of these studies, these are small numbers that are actually beginning to see left ventricular increase in left ventricular mass, but also myocardial fibrosis. And importantly, a question remains where there is obviously, and I bring this up because there's a debate tomorrow about the use of statins, is how much of this is a metabolic syndrome as seen in adults, where you've got risk factors such as smoking and age and diabetes, and a sort of that partly is there in children as well, but also the role of a myocarditis type picture and a fibrosis type picture. So I think there needs to be some work in teasing out the profile of cardiac disease. Importantly, though, that we are beginning to see impact on function and structure. And because it's symptomatic, it goes largely unnoticed. And we really need longitudinal studies. Another sort of a silent disease and comorbidity that we see in children that are entering adulthood with perinatally acquired HIV is chronic lung disease. And again, it manifests itself largely as having reduced exercise tolerance and poor lung function. And that tends to not make it to clinics with a complaint. And it's not, the phenotype is that of the cause, when you investigate it radiologically, is a small airways disease looking very much like a constrictive obliterative bronchiolitis, which is not visible on X-ray. And so in many, many clinics where, in busy African HIV clinics where X-ray is the main form of investigation, this will not be picked up. Unfortunately, you can't see this very clearly, but this is a high-resolution CT scan, and what you see is mosaic areas of attenuation, which is how you characteristically diagnose small airways disease. But again, as I said, diagnosis remains very difficult, and so a lot of these are treated recurrently with antibiotics and or anti-tuberculous treatment, rather than really trying to investigate further. And speaking to why this is a study done by some of our colleagues, showing that there was quite a strong correlation between reduced lung function and telomere length. So clearly signals that biological aging is playing a role in chronic lung, in at least this cardio-morbidity. But what I want to take you to, right, is not through a list of multi-system morbidities. I really want us to think about aging as a systemic concept, drawing from gerontology. So in older people, a concept of frailty, where as you age, you lose physiological reserve and intrinsic functional capacity. Your ability, for example, to see, your ability to walk, your ability to your intrinsic functional capacity reduces as you get older. And that's what we define as frailty. In the last only about 18 months, a concept called pediatric frailty has come into play. And that draws from gerontology, but it basically has much more of thinking embedded with developmental and psychosocial concepts in it, and talks about failure to gain capacity in age-appropriate growth and function. And that is the thinking I think we should be embedding when thinking about premature aging clinically in the context of people growing up with perinatally acquired HIV. And this is a conceptual framework about how I'd like to think about it, in that we have biopsychosocial resilience that we are increasing over particularly adolescence to time peaking in adulthood, and then slowly we lose that to the point of a threshold where we get frailty and then, of course, dying. And that occurs much, much faster and at a younger age in people with HIV. And that is variability depending on nutrition, psychosocial circumstances, education, etc. So that's a way to think about it, and not just thinking about single system morbidities. And if you think about pediatric frailty, like growth and function, one area which is really very prominent is growth failure. And that's retardation in linear growth and pubertal delay. Now, many of you will know that growth is severely delayed in children with HIV, and that has been manifest even in the era of antiretroviral therapy. And this is from the CIPHER global cohort collaboration with over 20,000 adolescents with HIV from 11 networks worldwide. And what you can see is that this on the y-axis is height for age in different settings. And what you can really see is that even as you grow older, that you don't really, in males or females, you get some catch-up growth, but you remain, particularly in sort of Africa and Asia, don't get your optimal catch-up, optimal growth that you would have if you were not living with HIV. And it's not just about being short. We know that poor growth is associated with increased mortality, delayed physical and cognitive development, and poor educational attainment. And very importantly, growth, musculoskeletal development is impaired because there's an interaction of linear growth and pubertal delay with musculoskeletal development. So there's a very strong dimension of growth that is going to affect your bones and muscle as well. And this we're beginning to see in older children and adolescents as living with HIV, even in the era of antiretroviral therapy. So this is a study that was conducted in Zimbabwe in the peripubertal period, and I will talk you through it because these diagrams are a little tricky to interpret. So on the x-axis is age in 2-year age blocks with Tanner stage 1, 2, and 3, 1, 2, and 3, 4, and then 1, 2, 3, and 4, and 5 in the older age group. And on the y-axis, you've got lumbar spine bone mineral apparent density, which is size-adjusted bone mineral, size-adjusted density, because clearly these are stunted, so you need to adjust for size or you overestimate bone density in males on the left and in females on the on the right. And the red lines bars are those with HIV, and the blue lines are those without HIV. And what you can really see, and the take-home message here, is that particularly in females, even in the older age group, you're seeing a difference in bone density even when they've reached Tanner stage 5. And there's considerable variability. So even after you reach puberty, bone mineral density is lower. And that particularly is problematic in women because these are the women that are going to start getting pregnant, are going to be breastfeeding, and are going to lose more calcium reserves from their musculoskeletal system. So clearly, and we know that one standard deviation away, minus one standard deviation, is equivalent to a doubling in fracture risk in adulthood. So these are concerning findings. It's not just, but these are asymptomatic. We are not screening for these. And then when we look at neurocognitive function, again, part of the frailty phenotype, if we look at function, and, again, there have been studies that have shown poorer neurocognitive function, but they have been in younger children. This is a more recent study, which is under review, conducted by our group, in 11 to 19-year-olds. So this is a much older age group, the mean, and again, on ART, the vast majority being virally suppressed, virally suppressed, having a viral load less than 1,000 copies per mil. But what you can really see is that when you use the KABC, which is the Kaufman Assessment Battery, with the mental processing index, which measures executive function, that you're seeing a really big difference between those who are HIV positive and HIV negative, even when you adjust for the following factors which were determined by a DAG. But if you use other indexes which also look at learning, planning, nonverbal index, you're starting to see differences. And so this is persisting into older adolescents. But it's not just about doing these tests. Importantly, these have functional consequences. And this is one of the few studies that has actually looked at whether these KABC, mental processing index findings, correlate with outcome. What I mean by outcome is things that influence people's ability to function every day. And what you can see is that difficulties paying attention, difficulty learning new things, forgetting things, reasoning slower than peers, and more than, 2 grades or more below expected for age are all associated with a low KABC. So what we're saying is that these are already having an impact on people's quality of life. So I think summing it all up, which I think Anita said very nicely, is we've done lifespan and increased lifespan through antiretroviral therapy, but really very overdue now to start thinking not just about lifespan, but also health span, which is the proportion of life lived with good health. And we need to continue to focus on the HIV care cascade, i.e. diagnosing and starting people with children with HIV on treatment sooner, because that, as Anita gave very compelling evidence for why that's important. But we are obviously seeing a larger cohort that will need care beyond that. And we need to understand the natural history and pathogenesis of these conditions, develop screening and diagnostic and therapeutic strategies, and importantly, managing these, and particularly developing educational support and mental health intervention. And I'm going to make a plug for a research program that we have just had funded called Artful Aging, which very much speaks to that, and I'll be very interested to speak to people who are working in the same area. This is a 7-year program in discovery science, which is really aiming for the first time to quantify pediatric frailty and to develop a frailty index, going beyond just looking at organ-specific issues to look at growth, physical function, and neurocognitive function, and a frailty index that could be applied to other chronic diseases that children growing up with HIV and reaching youth and adulthood are focusing with. It will characterize not one hallmark of biological aging, but drawing from gerontology, characterize hallmarks of biological aging by HIV status in this age group. A lot of this work in HIV field has been done largely in adults, and the stuff that's been done in children has really been in fairly small numbers. And this will characterize primary, integrative, and antagonistic hallmarks all on the same cohort. And what it will attempt to do is, which again has not been done, is to link these hallmarks of biological aging in terms of explaining pediatric frailty so that it can help identify gerodrivers and geroprotectors as a potential therapeutic avenue in the future. And so I'd be very interested in speaking to people who are working in the same space. So this is a really exciting 7-year program, and we're very excited. We'll be working across several institutions with the program based in Southern Africa. So I'll end there. Thank you very much. This is the work of many, many people, particularly people in my group. And I thank you very much for listening and for your attention.